Hello, good morning. Can you hear me this morning? If you can hear me, just please state that you can hear me. Thank you very much. Can you hear me? Okay, if you can hear me, thank you very much for your time here. I appreciate your time. So today we just have two case studies. The case study will serve as a way to remind us of what we learned before we went for holidays. That's the Christmas holidays, and then reignite some things that were not mentioned in class, reignite things that were mentioned in class, and also mention a few things that were not mentioned in class so that we can all have a more detailed overview of what the course is about. Okay, so that is the essence of this live stream. Don't miss it for any reason. If you're going to miss it, ensure you send your reports through your class rep. Okay, let your class rep be aware. Okay, all right. So case study number one. Case study number one. We are going to talk about salbutamol in acute asthma exacerbation. So first patient, Mrs. Williams, a 42-year-old elementary school teacher, presents to the emergency department with acute shortness of breath. So you should already know that this is more like a case of COPD or asthma. So shortness of breath, wheezing, chest tightness that started 3 hours ago after exposure to chalk dust in a classroom. All right, so this patient, she had a chalk dust infection. Chalk dust is an allergen for her. And so she has a history of moderate persistent asthma, usually controlled with fluticasone, 250 microgram. So what do you call it? From this drug medication, you should be able to have some information already in your head. Fluticasone is a corticosteroid and an inhaled corticosteroid. So you should understand where this question is going to already. So as you are reading case studies, what comes to your mind is that you do as if you are a patient, you are a doctor. You take the role of a doctor while your patient, the case study take the role of a patient. Okay, and you follow this process because you want to help this patient out. So case studies should look like a patient while you are the doctor or the attending nurse. Okay. And just like when somebody is complaining to you in condition, your head is already going around thinking of what to prescribe for the patient. That's what should be happening in this case. It's just that this case, most of the patients we see already have their drugs. They're just trying to intervene. They're trying to help them out, to make them better, to increase their quality of life. All right. So she has a history of moderate persistent asthma. Her vital signs on arrival are blood pressure 145/88. So this person is an hypertension patient. Heart rate is already tachycardia. Okay, increased heart rate. Then respiratory 28 breaths per minute. She appears unconscious and is using accessory muscles to breathe. I have some visibly tremulous, so she's having hand tremor. She tells you that she has been using a salbutamol inhaler every hour for the past 3 hours. All right, so that is an exacerbation of asthma already. That's a sign of exacerbation. All right, her current medication include fluticasone twice daily, salbutamol 90 microgram, propranolol 40 milligram twice daily for essential tremor, and oral contraceptive pills. Okay, so This is a critical patient I've seen. Normal life, most times many patients will not present to the hospital with one disease. All right, this patient is having essential tremor as a condition already. Then she's asthmatic, and she's on contraceptive pills. All right, so these three things we are going to study them together. Thank God I've taught you contraceptive. We are going to see if there's any interaction whatsoever. All right. So, what critical drug interaction exists in Mrs. Williams' medication that could be compromising in her response to salbutamol, and what is the underlying pharmacological mechanism of action? Okay, so I taught you cardiovascular pharmacology, and I told you that there are some drugs in the cardiovascular pharmacology, especially beta blockers, that will block both beta 1 and beta 2. All right, and I told you beta 2 agonists are drugs that are used as bronchodilators, as they are used to treat conditions like asthma. All right. So the answer, it goes without saying that propranolol, which is a beta 1 blocker, it also blocks beta 2. Will be the drug of interaction here. Propranolol and salbutamol. Salbutamol is beta 2 agonist, propranolol is beta 1 blockers. So beta 1 blocker will also have relative effects in beta 2 cells. So propranolol is non-selective to block beta 1 and beta 2. All right. So that is the reason why propranolol will worsen her tremor. If you notice, the question says her hands are visibly tremulous. That is, they're shaking. All right. So that is the major drug of action, and the mechanism of action is basically propranolol blocks beta 1 and beta 2 cells. All right. It's non-selective. So one of your nursing consideration for this number one question will be to give the patient a drug that is selective for beta 1. That is a drug that will not block beta 2. All right, so selective beta 1 blockers. Okay, so that is what you are going to give the patient. So who can give me an example of drug that is selective for beta 1? Who can mention one? I mentioned several in the class. Who can mention one? I'm waiting. Okay, so we have atenolol. Thank you very much, Yusuf. Thank you, Christas, and atenolol and metoprolol. So metoprolol. Okay, so they are selective beta 1 blockers. So you can place a patient on that instead of giving propranolol. All right, so question 2. As a attending nurse, you observe that Miss Williams' tremor has worsened since she's using repeated doses of salbutamol. She's distressed about the side effect and asks you if she should stop using the inhaler. Okay, how would you counsel her regarding this tremor, and what nursing intervention would you implement to address her concerns? Okay, now class, I don't know if I mentioned this class, but salbutamol is beta 2 agonist. Please pay attention, it's very important. Salbutamol is beta 2 agonist. Then beta 1 blockers are propranolol and the rest that we mentioned before. So a blocker is going to block beta 1 and beta 2. When you block beta 2, it's going to cause vasoconstriction, isn't it? Vasoconstriction, making worsening asthma case, like we have in question 1. The question 2 is not saying she's experiencing increased tremor. All right. Now, if we are giving her a beta 2 agonist, like salbutamol is going to cause bronchodilation. Salbutamol is also going to go to beta 1 cells and stimulate them. That's like a side effect. So one of the side effects of beta 2 agonist is the activation or is the stimulation of beta 1 cells, palpitation, tremors. I don't know if you understand. Propranolol blocks. So when it blocks beta 1, beta 2, when it blocks beta 2, it now becomes a side effect because you don't need beta 2 to be blocked. Beta 2 agonists, when you take them, when they activate beta 1's, beta 2 cells, you need them. But when they go to activate beta 2 cells, they become the side effect of beta 2 agonists. I really hope you understand. Okay, if you don't understand, drop it in the comments. I'll go over that again, or you can just repeat this video and listen. All right. So when something is blocking a receptor, when it blocks that its own receptor, is not a side effect. But when it goes to block another receptor that you do not send it, it becomes a side effect. When something is an activator, like an agonist, when it activates a receptor, is not a side effect. But when it goes to activate another receptor that is not supposed to activate, it becomes a side effect. So beta 2 agonists on this side, they are like activators. Activate beta 2 cells. Beta 2 cells will cause bronchodilation in the lungs. But beta 2 agonists will not just only activate beta 2 cells. They sometimes go to activate beta 1 cells. When they activate beta 1 cells, they start giving the effect of beta 1, and that can become a problem. And that's where we have tremors and palpitation and the rest. We saw her reading was 118. That's already increased heart rate. Okay, so it's around 60 to 100. That is the moderate range. All right, so that is one of the things that you can explain to her. Oh, the reason why you're having this increase is because of salbutamol. All right, salbutamol does this. Salbutamol also causes stimulation of the muscles, of skeletal muscles. You understand? So that's one of the reasons why you have these tremors and the rest. All right. Then you can also explain to her that tremor will reduce over time as the drug expires, because beta 2 agonists usually expire within 4 to 6 hours. Okay, that's the half-life. So it means that tell the patient, oh, take it, and usually within this period that this salbutamol will have effect. So explain the reason for the side effect, and most time when you explain this reason, the patient understand. All right, and you'll be able to bear it within this period. All right. Then, and when you give them that advice, it will help them accept the medication and take it the way they're supposed to take it. So part of the questions I say number 2 is, how would you counsel her regarding this tremor? All right. And what's the next question, that and what nursing intervention will you implement to address her concerns? All right. So all you just have to do is counsel her, let her understand, give her clear explanation to why it happens, and then she'll be able to understand. Whenever she sees it, she's calm, she's not worried. All right. Then you will tell her that no matter what happens, she should continue taking her medication, that she's okay. Once patients get reassurances like that, they are able to continue that medication. All right. So question 3. The physician orders nebulized salbutamol 5 milligram immediately, because of course the reason why she presented to the hospital is because of her struggling. Okay, she appears anxious, unnecessary muscles to breathe, her has some visible tremulous. It tells you okay. So that's part of the questions. All right. So part of the question is that the physician orders nebulized salbutamol 5 milligram immediately. Before administration, you notice Miss Williams' heart rate is 118. All right, her heart rate is increasing. Her heart rate is increasing. Okay. What comprehensive cardiovascular assessment and monitoring parameters should you establish before administering nebulization? All right. Now, I just told you that beta 2 agonists will stimulate beta 1 cells too. Beta 2 agonists will stimulate beta 1 cells. And what do beta 1 cells do? They will cause increased heart rate, contraction, pressure. You understand? Palpitation. You understand? So because of that, before you administer the nebulized salbutamol, you are supposed to check her heart rate. All right? Check her heart rate before you administer it as a nurse. You do that every 10 to 15 minutes. All right? Then you do that every 10 to 15 minutes before you administer it. Then when you are giving her the nebulization, during the process, you now also check every 5 minutes. All right? Then if you notice that the heart rate increases more than 140 beats per minute, you stop. All right. So you stop and you call the physician. So that is where the baseline. I don't think I mentioned this in class. I just told you the effect. Okay. However, heart rate that is more than 140 beats per minute, you withhold nebulization. Why? Because I told you beta 2 will also causes that. So there's no point increasing continuing giving her salbutamol, which is a beta-2 agonist, continue giving her salbutamol when her heart rate is shooting up, you are going to eventually cause cardiovascular failure for her. All right. So you withhold that and let the doctor come to address that heart rate. All right, in order to prevent any cardiovascular failure that's supposed to take place. All right. So that is just basically what you're supposed to do for that person. So number 4, Miss Williams admits that she has been using her salbutamol inhaler 4 to 5 times daily, which is wrong. I don't know if I mentioned in class that salbutamol inhaler ought to be administered when necessary, when needed. Inhalers, because they are beta-2 agonists. They are usually used to treat the symptoms of the disease, like the effect. What is the disease? What is this asthma condition causing in this patient? It's causing shortness of breath. So salbutamol is given to reduce this effect. So if a patient have to use their Ventolin inhaler or their salbutamol inhalers more than twice a week, it means that asthma is getting worse or that asthma is not properly managed. I don't know if you understand. Okay, so now this patient is telling you they are using the inhaler 4 to 5 times daily for the past 2 weeks. Okay, and thought this was acceptable because it provided relief. What critical nursing indication should you provide regarding this pattern of increased salbutamol use? And what would you make regarding her overall asthma management? So I've mentioned before, because she uses up to 4 to 5 times daily, it totally indicates that she does not have complete control or the asthma condition is worsening. All right. So what you may likely do is to refer her to a consultant who should assess her care, probably add a corticosteroid. Okay, I think she's on fluticasone. So it means that she's not taking a fluticasone corticosteroids properly, or she's not adhering to that. All right. So if you're using it more than twice a week, please remember this: twice a week. I think that should be your OBJ question. Twice a week is the baseline for the use of Ventolin inhalers. Any frequency that is more than that is a sign that asthma is not being managed properly. Okay, or any use of inhaler that is not because of a physiological activity that the patient wants to undergo. For example, if a patient know that they are about to go do an exercise is going to make them have shortness of breath, stress their respiratory rate, and they want to take their Ventolin inhalers, that is properly okay. If they go for exercise, let's say 3 or 4 times a week, that is not counted. What I mean by twice a week, I mean that if the patient undergo any asthmatic crisis, and then has to resort to the Ventolin inhaler, the salbutamol Ventolin inhaler precisely, it shows that this patient asthma condition is not properly managed. All right. So that's what you're supposed to explain. To tell the patient that salbutamol inhaler is medically used for relief, to relieve symptoms of the asthma. It's not used for treatment. I don't know if you understand. I don't know if I stress this in the class enough. It's used as a relief and not used as a treatment. All right. Then whenever they're having shortness of breath, waking up in the night, when patients are waking up in the night, sweating in the night, and then are unable to do some activities they're supposed to do before because of weakness, general body weakness, is as a result of asthma worsening, like the exacerbation of asthmatic attack or the asthma disease. Okay, so that's that for that. All right. So let me see. So the next question. Ms. Williams demonstrates her inhaler technique for you. She shakes it, places it in her hands. Forget the pronouns, a mistake. Places in her mouth, presses the canister, then immediately breathes in quickly. Holds breath for 3 seconds and then wait 50 seconds before taking the second puff. Identify all the errors in this technique and explain how each error could affect drug delivery and potential systemic side effect. All right. So basically, the point here is this, that inhaled corticosteroids, or sorry, inhaled salbutamol actually have the proper inhaled corticosteroids actually have the proper um, method of administering it. You don't just administer them anyhow. All right. So I think I taught you in class the process for inhaling or for using process for using inhaled corticosteroids. Now let us look at her what she mentioned. She shakes the inhaler, places it in her mouth. She did not mention exhaling. So remember to say that. Okay, she has to exhale. All right, I can see that if you ND and RN students are here, please, RN and ND students, this is not your time. 7:45, I told you, and it's not yet 7:45 last time I checked. So please wait and come in when it is that time. All right, thank you very much. So she shakes the inhaler, places it in his mouth. She ought to exhale. This is like this you have to watch out for. Exhale properly or exhale completely, and exhale through the mouth. All right. Then press the inhaler in her mouth, presses the canister, and then immediately breathes in quickly. No, you do not breathe in quickly. You breathe in slowly with the mouth. All right. And then you hold your breath for 10 to 15 seconds, not 30 seconds. 10 to 15 seconds, not 30 seconds. 30 seconds is too short. And then wait 15 seconds. You don't wait for 50 seconds before applying ventilator. You wait for at least 1 minute before taking the second puff. All right, so that's the errors, identify the errors. All right, so all of these are the points you're supposed to pay attention when administering inhalers. Now, I said in the question, identify all the errors in this technique. I explained how each error could affect drug delivery. Now, the fact that she breathes in quickly is one of the errors that will affect drug delivery. When she breathes in quickly, she takes in all the salbutamol particles into the system, and that will cause systemic administration, systemic absorption of that drug. Instead of the drug to be inhaled slowly, that will eventually enter into the respiratory tract. Quick inhalation will take it down to the esophagus and then into systemic circulation. And this patient will have increased side effects of salbutamol, instead of just reduced side effect that comes with what using the inhaler. All right. So that's that for that. So the second case study, which is the last case study, which is the last case study. All right, so let's continue. Mrs. Sarah Martinez, a 28-year-old graduate, has been newly diagnosed with moderate persistent asthma. Her pulmonologist has prescribed fluticasone, inhaled twice daily, and salbutamol, 90 micrograms a day. She presents to the clinic for asthma education before starting this medication. So she came to you to get educated on the drug. Sarah is a non-smoker but admits to high stress levels due to her academic workload. She has no other medical conditions, but she takes oral contraceptive pills. During your discussion, Sarah revealed she is anxious about starting an inhaled corticosteroid because she's worried. Oh, I'm taking fluticasone. Why? Somebody has told her that because oral prednisolone is used for rheumatoid. Okay, sorry. She reveals she's anxious about starting an inhaled corticosteroid because her roommate, who takes oral prednisolone for arthritis, has gained significant weight and developed facial swelling. Her face is swollen. So that says she would prefer to just use the Ventolin inhaler instead of what? Corticosteroid inhaler. All right, question 6. That's continuing from the previous case study. How would you address Sarah's concern about systemic circulation? So, somebody from the HNE class, will systemic administration and will oral corticosteroids and inhaled corticosteroids give the same systemic administration or systemic absorption? In the case of oral and inhaled corticosteroids, I'm asking a question, please I need a response. In the case of inhaled corticosteroids and oral corticosteroids, okay, no. All right, thank you very much. It therefore means that we are getting the point. So inhaled corticosteroids will definitely not lead to the same level of what do you call it? absorption, systemic absorption. All right. First of all, what you just have to do, just advise her, oh, that one is oral tablet and this is inhaler. So inhaler will not lead to systemic absorption. And then you explain to her that all the side effects that come with oral corticosteroids, she won't get it, like moon face, immune suppression, and the rest. All right. And also, the typical absorption rate for oral corticosteroids is about 100%. But for inhaled corticosteroid like fluticasone is about 1%. So she may not likely have corticosteroids in her blood system, just about 1% of what she consumes. You understand? And that will not lead to her, sorry, that will not lead to her having all the side effects that her friend had mentioned. So number 7, Sarah asks when she should use fluticasone versus salbutamol. So she has asthma and she's giving both salbutamol and corticosteroids inhalers. And she's asking when she should likely use it. So she wants to know if she can just use one. All right. And then she wants to also know if she can use the corticosteroids for whenever she's having shortness of breath and the rest. Okay. So I think I have to say something clearly here. You see, the difference between the salbutamol and the corticosteroid, I don't know if I stressed this in class. Corticosteroids, inhaled corticosteroids are used to manage the shortness of breath that comes with asthmatic conditions. However, salbutamol are used to relieve the symptoms that come with asthmatic condition. A good example is when you have increased temperature in malaria. Somebody's having malaria 2+ and have increased body temperature. Panadol is used to manage the symptoms of the increased temperature. The artemether is used to treat the parasites, which is plasmodium in the blood. So if you are using paracetamol every day, you are not treating the parasites. That's synonymous to somebody who's using salbutamol inhaler every day without using what? Corticosteroids. When you are using corticosteroids have a way of remodeling the upper respiratory tract and reduce the bronchoconstriction that occurs as a result of the inflammation in the bronchioles. However, salbutamol helps to reduce the wheezing and the shortness of breath that comes with asthmatic attack, which is the inflammation. So when you want to control that inflammation, you want to control the tightness, it is corticosteroids we use generally. That's where fluticasone comes in. However, salbutamol comes when, let's say, because of carelessness or because you are unsure, you don't know, you encountered an allergen that is causing immediate shortness of breath and you quickly need to do what? To resolve it. Corticosteroid fluticasone should not be used in case of emergency. However, salbutamol is only used when necessary, only emergency. So when a doctor prescribes fluticasone inhaled corticosteroids and salbutamol inhaled beta-2 agonist, a patient should use inhaled corticosteroid routinely like the normal medication they use every day, usually 12 hours, morning and evening, continuously. Then they have salbutamol inhaler for emergency. So the salbutamol inhaler, I told you already in the previous case study, should not be used except at least or at most twice in a week. That will show this person's asthmatic condition is controlled. All right. Then anything other than that means that the person's corticosteroid is not being taken properly. So that is that for that. So the last question, you are demonstrating proper inhaler technique to Sarah, including the critical post-administration step. What is the single most important nursing instruction you must emphasize regarding what Sarah should do immediately after each fluticasone dose? Okay, so this is corticosteroids class, and when inhaling corticosteroids, please, I just need 5 more minutes for the HN, for the ND and the C squad that are joining. I need 5 more minutes to wrap up HN class. So for the inhaled corticosteroid, one of the most critical steps is that after every dose of the corticosteroids inhalation, They have to rinse their mouth properly, gargle properly, and spit out throughout. Please do not swallow. Okay, you rinse, gargle, and throw out. Why? It's because corticosteroids are known to reduce the immune response in the body, and therefore they will lead to the proliferation of fungal growths. For example, Candida albicans in the mouth, also known as oral thrush. So that is one thing you have to tell your patient after taking every corticosteroid inhalation. After taking the dose, gargle with the mouth, switch left and right, gargle and spit out. All right, that way it reduces the deposits of the corticosteroids in the mouth and therefore can allow the patient to live free of any infection, any oral infection or fungi or fungus, and then continue taking their medication as they should. So how do you know a patient who is not rinsing their mouth properly? The availability of oral thrush. Then you can also tell the patient, always check your tongue in the mirror every 2 to 3 days to see if there's any deposit of white matter. Deposit of white matter on the tongue is a sign that they're not doing the rinsing properly. And those are signs of early fungal growth that can be treated with topical fungi, antifungals that can be used like nystatin drop. All right. So that's that for that class. Thank you very much. And yes, it happens. It happens in corticosteroid, mostly corticosteroid, Yusuf. So I thought that happened in salbutamol inhaler. It happens mostly in corticosteroids, okay? Because corticosteroids helps to reduce the immune response, and therefore that is one of the major side effects it happens. All right, fluticasone, the use of corticosteroids inhalation. So I'm sorry, inhalation corticosteroids. So that's that for that class. If there's any more information, I'll pass it across to you. Now for the link for your CA this morning, I'll send that to your class rep. I don't know if he's online now because he told me he'll be traveling. I'll send that to let me just send to a few of you on WhatsApp. Yusuf. I'll send to Yusuf. I'll send to Zion. And then I send to Daniel. Blessed, assistant class rep, please send me a message. I think I should have your number. In case like this where maybe your class rep takes permission not to be present. All right, then who again am I supposed to? So please drop it on the class page so that everyone who is not here can fill. And please, this form is going to open for just 10 minutes. 10 minutes as much as possible. Submit as early as you can. I'm not going to open it up after 10 minutes. So fill it as soon as you can so that I can quickly record your scores. Thank you very much. Okay, Blessed, thank you very much. I see your message. All right. I think the link should be in your class group now. Thank you, everyone. HND, you can exit the class now. Let me quickly take the end class. Thank you very much. ND and RON, good morning. If you can hear me, please say good morning. Thank you very much. Can you hear me for the end class? Please let me know. All right, good morning, class. Thank you for your presence. So, any HNE students still here, please, you have to leave. Your questions have been sent to your group. Go and fill them properly. All right, so the RN and the two class. So we have just very few case studies. I will do only contraceptive today. And I want us to quickly wrap this up before 8:30 so that we are done. Thank you for your time. Okay, so case study 1. Blessing is a 22-year-old university student at the College of Nursing who visits the family planning clinic requesting contraception. She's sexually active with one partner and has regular menstrual cycle and no chronic illness. She does not smoke and has no history of hypertension or migraine. So question 1, what class of contraceptive is most appropriate for this patient? Who can tell me that? I mentioned this on Wednesday and on Monday last week. What class of contraceptive is most appropriate for this patient? Who can mention for me? Okay, combined oral contraceptive. Somebody said oral contraceptive. No, that's not the word. Oral, there's progestin-only oral contraceptive. There's progestin and estrogen. That is the combination. All right. All right. And I told you that the class of patients who need it are those who can take theirs daily. All right. So, explain how combined oral contraceptive work. They causes the thickening of the cervical mucus. They prevent ovulation. Okay. They prevent ovulation. And they prevent implantation. That's the endometrium where the egg's supposed to stay. They make it they make it inhabitable. All right. So the endometrium cannot rest. The endometrium cannot contain any fertilized ovaries. All right. So question 3, list common side effects of combined oral contraceptive. Who can mention one for me? I think I mentioned it in class. Who can mention one side effect of combined oral contraceptive? One side effect, class, I'm waiting. Okay. Mood swing, irregular bleeding. Thank you very much. I've seen what I'm looking for. I've seen, who is this person? Thromboembolism. That's Nan. What is your name? It's fine. All right. So that's one of the side effects of it. For patients, that is contraindicated for patients who are above 35 years. You see the age of that patient there is placed at 22. So in another case study, I can give you a patient is 33 years, patient is 37 years, patient is 40 years. You are supposed to know that. Do not give COC no matter what. All right. It can also cause weight changes, can cause headache, can cause bleeding. All right. Stage 2 nursing consideration before starting COC. Number 1, rule out pregnancy. All contraceptives that you're going to give, ensure you rule out pregnancy. Ensure you rule out pregnancy. That can save you a lot in this life that we are in. Do not give a patient or do not start a patient on contraceptive without checking their pregnancy, doing the pregnancy test for them. And mostly not with strips. Mostly use a blood test for them. All right. Rule out pregnancy. Then ask if they smoke. There's a social history. Then ask if they have any clotting disorder. All right. So question 5, in which situation should COC not be recommended? In patients above 35 years, patients who smoke, patients who have uncontrolled hypertension, patients who have history of thrombosis, deep vein thrombosis. Okay, patient with migraine. Those are examples of patients of cases where you do not give COC. And again, COC is a combination of estrogen and what? Progesterone. All right. So that was that for that. Second case study. If you have any questions as I'm talking, please just state it, and I will trash it as soon as I'm done. For those of you who don't stay for the classes, but they want to answer the questions, I'm just smiling because most of the things that I'm going to ask here are case study specific. If you are not in the case, if you don't know the case study, you wouldn't know what response or what answer links to another answer. All right. Thank God the name of the patients are here. So please pay attention. Those of you that attend the classes, know the names because I'm going to mention their names in the question. For example, Amina is a 30-year-old woman. Amina is this case study 2. All right. So the person's name that's here in case study 1 is Blessing, a 22-year-old student. All right. So if I were you, I will screenshot these case studies. All right. Then case study 2, we have Amina is a 30-year-old woman, 6 weeks postpartum. So she just gave birth. And breastfeeding exclusively. She wants a long-acting contraceptive that will not affect her breast milk production. All right, probably this ambitious. She has had so many children and then she wants to stop. All right, and probably she also had history of lactation amenorrhea method has not worked for her, where they use breast milk to prevent. Natural method, remember natural method? I told you withdrawal, lactation amenorrhea method, and the normal cycle method. Okay. So question 1. Which contraceptive class is most suitable for this patient? All right, so you give Depo, that's a progestin only. For example, we have Depo-Provera. Now, one of the side effects of Depo-Provera, I think I don't know if I mentioned in the class, is that when they eventually want to start giving birth, it takes some time. It's not just this Depo can stay for up to 3 months, 90 days, sometimes 6 months. But sometimes the effect can last up to a year. Patients may not be able to take in or conceive until after a considerable number of time, that you can give her the risky chances. All right, so you may wait up to a year before you can be able to take in again if you want to give birth. So start trying early enough. All right. Why is this method preferred in breastfeeding mothers? And the reason why this method is preferred is because it does not increase estrogen level, basically, so therefore does not suppress lactation. Lactation is increase of prolactin, okay? It's safe for breastfeeding and does not contain estrogen. Look at I mentioned that it does not contain estrogen. All right, question 3. How does Depo-Provera prevent pregnancy? The same way it suppresses ovulation, thickens mucus, and prevent make the endometrium unsuitable to house any fertilized eggs. All right. So number 4, least common side effects of Depo-Provera: irregular menstrual bleeding, weight gain, delayed fertility is also one of them. Patients may not be able to give birth after, even when they want to. You understand? All right. Then it can also cause osteoporosis. So women who are older, let's say 35 and above, you want to tell them that they should not engage in tedious work, they should not run, they should not fall as much as they can, because it will make the bone density very light and can delay bone healing. All right. So state 3 nursing consideration before administration of this progestin-only Depo-Provera. Now, class, one of the nursing considerations is to check for pregnancy. I don't know if you understand. Remember that. Always remember it. Just like the way nausea and vomiting are side effects, also always know that one of the nursing considerations for contraceptives, always check pregnancy status. All right. Then you administer alongside vitamin D and calcium because of the bone effect. Okay. Then you educate patient about chances of delayed fertility. Okay. All right. So that's that for that. I think the last question in this case studies: in which special situation is Depo-Provera recommended? Women who are breastfeeding, women who cannot take estrogen. All right. Women who cannot comply. For example, all those people also forget to take their what do you call it? Who forget to take their COC, their combined oral contraceptive. All right, so that's that for that. So case study 3. Somebody's asking Jennifer Sayande. Sir, what class of contraceptive is Depo-Provera? Depo-Provera is under hormonal contraceptive. All right. Depo-Provera, COC are under hormonal contraceptive. Under hormonal, we have combined oral contraceptive, we have progestin-only, and Depo-Provera is an example of progestin-only. All right. So Sade or Shade, according to my Yoruba friends, is a 19-year-old undergraduate student, maybe from Edo College of Nursing, who presented to the clinic 36 hours after unprotected sexual intercourse. She's anxious and says the condom broke during the intercourse. Her last menstrual cycle was 12 days ago. So this patient will be at risk. This patient will be at risk of getting pregnant. This patient will be at risk of getting pregnant, okay? Because our menstrual cycle is 12 days, last menstrual period was 12 days ago. So it therefore means that our ovulation is either in 2 days, and I told you sperm can last around 5 to 7 days. So what type of contraception is indicated for this patient? Who can mention? What type of contraceptive is who can tell me what should be used? Is it COC? Emergency contraceptive. God bless you. Emergency. Okay. Thank you, everyone. I think I have a question. I saw a question here from Victoria Osize. Oh, this Osize. What about Noristarine? Is it suitable for breastfeeding? Yes, Noristarine is a brand of progesterone. Okay. So, and it contains only progestin, I think so. So it is good. Any progestin only is good for lactating mothers or breastfeeding mothers. All right. So back to my question. What type of contraception is suitable for this patient? Emergency, correct. So that's not the time to start giving, let me give you the Depo-Provide injection. Let me start giving you this. No. You give emergency contraceptive. All right. So question 2. Mention 2 types of emergency contraception available. The first one is levonorgestrel, and then levonorgestrel and what do you call it? Copper IUD. I think I mentioned that in class. Copper IUD is a good example of emergency contraceptive. The question 3: which emergency contraceptive method is most suitable for us? Most suitable for SADE. Most suitable is levonorgestrel. All right, because it is most active within 72 hours. All right, most activity 72 hours and highest efficiency within 24 hours. All right, so it's easily available, and you can use it. It can be self-prescribed. Patients can use it by themselves. All right, and how does levonorgestrel work? The same way: prevent ovulation, prevent fertilization, and however, it's not an abortifacient. Emergency contraceptive is not an abortifacient. Please know that. All right. Least common side effects of levonorgestrel. It can cause menstrual irregularities. All right. Patients unable to have proper menstrual flow. All right. And there's nausea, vomiting, and there's breast tenderness. Patients start having tender breast feeling. Okay. Then state for nursing considerations when administering emergency contraceptive. So rule out pregnancy first. So in that case of this patient coming to your clinic, you can do a PT strip test, or you can do a blood pregnancy test. Now, it's not like the pregnancy, the sexual intercourse 24 hours ago can cause pregnancy. No, it's to prevent, to ensure that the patient was not initially pregnant. I don't know if you understand. Patient can tell you they see their menses. And according to you in class, you told me that you can see your menses even while pregnant. So rule out pregnancy first in your clinic before you administer emergency contraceptive. Just know that, okay? So administer as soon as possible after intercourse. As soon as possible. Okay, I told you of a patient who usually takes emergency contraceptive in the pharmacy. All right, as soon as they buy it, she just buy can water alongside. That is as soon as possible. That is the best as soon as possible. So a patient is coming to complain to you, don't tell her to go home, tell her to buy it immediately and take it. But if you have it in your clinic, you administer it to them immediately. All right. Then after that, you can click. I'll tell you nursing concentration that you can use. You can click on proper contraceptive. You can now teach her the different contraceptive routes for her to use instead of to consistently take emergency contraceptive. Okay, you can then tell the patient to take contraceptive, use a different type of contraceptive measures. All right. So, last question for today says, in what special situation is the copper IUD preferred as emergency contraception? All right, copper IUD can give um, cover up to 5 days after intercourse. Okay, it can give up to 5 days. So if a patient comes to you and tell you, "Oh, I had sexual intercourse on Monday and that today is Friday," you can administer or you can refer to a clinic for to get this copper IUD done. All right, and then it can give an effect. It can give a contraceptive effect almost immediately. What generally copper IUD does is that it ensures the sperm do not survive. Okay, and it is toxic to the sperm, and then basically what it does, copper IUD, what it does is that it just causes inflammation in the endometrium. So everything that comes around there dies. They don't survive. Okay, so and usually it actually protects for a long time. So the patient can use it to prevent that pregnancy and also leave it for subsequent long period of time. Okay, so and it does not work with hormone. It's not under hormonal. It's not under hormonal. It's not under hormonal contraceptive. Yes. Somebody said, "Is copper IUD more effective than levonorgestrel?" No, there's no effectiveness here. It's just that they are used with their different specificity. Copper IUD can be used for up to 5 days. Levonorgestrel can be used for just 72 hours, which is about 24. It's 3 days. Okay. So, of course, somebody says, what are the side effects? What are the side effects of copper IUD? Copper IUD, basically, it causes inflammation. I'm just trying to give you an idea what it does, what the side effects will be. If it causes inflammation, it can lead to slight pain. It can also affect the menstrual bleeding. You understand? It's either the patient does not see their menses at all, very small, or the patient bleeds heavily. Okay. Then I think then bleeds heavily or regularly. So this patient can be bleeding every 2 weeks. All right. So those are one of the side effects of copper IUD. So basically, what copper IUD does, is not hormonal. It does not do anything that has to do with hormone. It just provides an environment where the sperm cannot survive, and everything that is alive cannot survive in the endometrium. All right. So that is it. I thought copper IUD releases copper ions that are toxic to sperm. It's not the same thing we are saying. That is Vomia precious. That is it now. Making the environment for the sperm to die. And the point is, it does not work with hormones I mentioned before. And then it's not just about the copper ion that it releases. Okay. That inflammation it causes around the endometrium prevents sperm and anything that is any living cell to survive there, and then causes it to die off. Okay. Yeah, if confirmed there's no pregnancy. Okay, sir, can we still give copper IUD for unprotected cells in 2 days of unprotected cells to be on the safer side? Yeah, Jovita, I will do. You can give copper IUD, but copper IUD is for long-term contraceptive. It can stay for up to 5 to 10 years. So does the person not want to get pregnant again in 5 to 10 years? I don't know if you understand. So that is the reason why the best contraceptive in this case is levonorgestrel, which is Post-inhalation, the brand that we have. You understand? If you are giving copper IUD, you are trying to prevent pregnancy and give contraceptive effect continuously. Meanwhile, levonorgestrel, which is an emergency contraceptive, you're just trying to prevent for that particular time. For example, a student that is 19 years old, like this case study, does not want to get pregnant, had unprotected sexual intercourse, does not want to get pregnant today, and you give her copper IUD. If you put in copper IUD, what you're trying to do is that you are trying to tell the patient, oh, you will not get pregnant today, and also every other sexual intercourse, you'll be safe from pregnancy. You'll be safe from, but the patient asks that. The patient asks for that. Do you understand? That's what you should ask yourself. If the patient doesn't ask for that, just give levonorgestrel and fine. Then also, it doesn't take time to administer copper IUD anyway. 5 to 10 minutes, you are done. And lastly, if a patient comes to you and he says they had unprotected sex, basically you just have the period. The period is within Post-inhalation, which is an oral drug, easy to take. You quickly give levonorgestrel and the patient is okay. Copper IUD require you to go to the hospital because you cannot administer it in the pharmacy. Okay, you cannot administer it. It's not every clinic that you can do that. Although it is a simple procedure, within 5 to 10 minutes you are done, but it requires expertise, and it's not readily available as much as levonorgestrel. So, and again, if the period is within 72 hours, give levonorgestrel. If it's more than 72 hours, you can say, okay, visit so and so clinic. They will give you this to help you, since this is up to almost a week now. You understand? So that is the unique cases. So I don't know if I said the question that we test this knowledge in the exam, but I believe that you can discontinue the use of copper IUD for like after a month of yes. But what was the point? What's the point of discontinuing it? You know what I mean? What's the point of discontinuing when you could actually have used Post-inhalation? Except in the cases where it is up to 4 or 5 days, then you cannot take copper IUD and discontinue it after a month or 2 months. Okay, you've got to what you want. So that is the idea. All right. So that's that for that class. Thank you very much for your time. I really appreciate it. Now, what I want to say is I noticed that a lot of you missed last week's case studies and the class. Please try not to miss the case study class. The questions I ask are case study specific. So the questions I ask are case study specific. And then we should ensure we are present. We should ensure we are present during each class. Okay. All right. I think I'm seeing a question from someone. Is saying, can cyanopress giving case study too? Oh, I'm done for the case study. Probably in class you can ask me this. I'll just talk about cyanopress. Cyanopress is a brand. I think it's a brand of contraceptive. I can't remember the company now, but it contains Progestin-only. All right. So that's that for that. So I will send to your class rep the link. You should click on it and start answering. So you can go to your class group now and see you in class this week. God bless you.